It's what you describe, of course, as like the list of all the things down the bottom of the list, the bad ones you don't want to go to. Every single medicine that's used in treatment of psychosis is potentially toxic. Now, paradoxically, clozapine, which is the most toxic, which you'd think would kill people left, right and centre, is the safest drug in psychiatry. How does that come about? How can something that we know affects the bone marrow, the heart, and about everything else, how is it safe? It's because people pay attention to side effects. And I'll come back to the problems your daughter have had, exactly the same as the general physical health problems. It's people don't take it seriously. Now, just as a matter of interest, as I walked in here, no one, I bet, today is going to talk about movement disorders caused by medicine. You know, things like tardive dyskinesia and so on.
No. The first gentleman from health ran through that extensively.
Right, well, I've seen at least 5 people in this room who find marked movement disorders. No one's sort of mentioning that. That was the old problem. The new generation of people can't even see that. So some of the problems that your daughter had would just go over the new generation of doctors. Other things should have been obvious. Unfortunately, what we try to teach medical students for 20 years with probably no success is every single person has a different reaction to every different antipsychotics. It's called cost-benefit analysis. And I've, as someone who spent 20 years internationally being what's called a psychopharmacologist, studying the action of drugs in the brain, I've never met 2 people who are the same. Every person should be individually treated. And that sounds like a motherhood statement. But the minute you don't do it, something goes wrong. And this is the whole problem of unfortunately, it's sort of like the loss of the doctor, the family doctor. It's also the loss of contact with, say, a treatment team who know you inside out. And the minute you get some little quirk, they say, I know what that is because I know you.
And so, Tim, is a practical thing. I'm not saying it deals with everything raised by this form, which obviously is very profound, but is one of your take-home messages, search the world for a really proactive and competent GP?
Every person with psychosis should have a GP. Unfortunately, people have been trying to do that for 20 years and it's never worked. But the answer is yes. If it were possible, even doctors should have a GP, as I've just discovered. So there you go. And I'm only 56. It's taken me 56 years to work out.
Can I just say, just on that, it's a bit similar to the question, can you effectively help people with weight loss and with cutting out smoking if you don't do it yourself? The truth is, the research shows an enormous number of doctors don't have GPs. Seriously, that's a fact. And I'm just wondering if there is some merit in the view that the issues that you so clearly are feeling really, despairing about, the capacity of the system to really care and do what they need to do, that until doctors themselves have a key coordinator of care who knows them inside out and know personally the merit of it, will they advocate in the system to have that for the vulnerable? It's possible. You have to walk the walk and not just talk it. I just throw that out there.
Can I point out something to do with medicines? When I was younger, I used to make all the registrars, the ones trained to be psychiatrists. In the old days, is the bad old days. But I used to make them take the smallest tablet of haloperidol. It was 0.5 milligrams.
And what is that?
It's one of the old-fashioned antipsychotics that's akin to taking weed killer, but it was the standard treatment. But the point is, even on those tiny doses, each of the students had to write what the experience was like. And even 20-something years later, I still meet that group of people who are all now professors and famous people saying, I can remember you doing that, and I've always used tiny doses of medicine. So that fits in with what I'm saying. Until someone in the health department in the state I was in found out I was doing it. The issue is not just clozapine, it's also olanzapine, which is another one of the most popular drugs in Australia for some reason. Now, both of those drugs, all of the drugs that we have, let's say 90% of them, to be broken down and excreted from our bodies, at least part of that excretion process occurs in our livers. We have special enzymes there that grab hold of these foreign substances and break them down and make them neutral and excrete them. Now, one of the, if you like, the enzymes that breaks down clozapine and olanzapine into forms that can be dealt with. Let's just give it a fancy name. Let's just call it CYP1A2. Now, that enzyme, in the presence of the tar in cigarette smoke or cigars or pipe, in the presence of the tar, this enzyme multiplies millions of times, because what does tar in cigarettes have? It has all of those cancer-causing agents. And so our body knows this, so it multiplies this enzyme to break down all of the proto-cancer agents. Unfortunately, the same enzyme can't distinguish between that and clozapine and olanzapine. It breaks them down very, very rapidly. So that was a beautiful example given. Not that I ever see people get stabilised in hospitals, but if they were to be stabilised, so their blood levels of clozapine have got to be just the right amount. They go out, they start smoking. Within a week to 2 weeks, their levels can drop by 80 to 90% in some people. And of course, as the levels drop rapidly, it's not just the clozapine or the olanzapine doesn't work. With clozapine, of course, you can get what's called a relapse psychosis, which is not schizophrenia coming back. It's actually a pharmacological psychosis that damages the brain. So it's like the person's just chucked the medicine away. So everyone in hospital, or not even in hospital, if we're talking about smoking and those drugs, needs very, very, very individualised advice about if you're going to change your smoking, how much do you do, how much do you don't do, and everything. So anyone here who's in contact with anyone on clozapine or even olanzapine should be talking about change in smoking is dangerous.
And it's clear that ongoing counselling is absolutely essential. And yes, people do go out smoking as much as they can in between. Just like in a lot of the mental hospitals, you don't get a portion of food. You go out and serve yourself, and the lovely lady tries to feed you as much as she can, so that you put on weight rather than lose weight because you're eating double the amount of calories. So it's something I think I'll be very happy to talk to you in the break rather than doing an open forum. Can I just say though that one of the keys has been individualizing treatment, and I applaud the lady whose daughter had 5 admissions. One of the things which I've been rather fearful of is that it's a drive to try to mechanize the treatment of metabolic disease in people with mental illness. In other words, if your cholesterol is high, do this. If your blood pressure is high, do that. And if you have diabetes, do that. And it's completely unindividualized without any sort of form of monitoring. So every tablet that we give you for blood pressure and cholesterol does a world of good, but it also has potential for side effects. For example, we have to monitor kidney function, liver function, and muscle function, etc. So again, the key is to find a good GP or good mental health professional who actually can coordinate the care and follow up these patients or your daughter appropriately with the right blood tests, the right blood pressure monitoring, and the right intervals.
Roger, can I just say one quick thing and ask for a brief comment, and then I will go to the next group. What's already been raised in the room is that the side effects from multiple medications can be so devastating on you physically. Who wouldn't be non-compliant? This is one of the points that's been made. I've listened intently to both of you, and I'm left with the impression that to manage this well, you need a highly motivated general practitioner who does individual research on pharmacology and interactions and seeks professional advice to get you on the right mix of the right doses on a constant monitoring basis. And I suspect that's quite a hard thing to find, but what would you say to, I'm sorry, the pills are worse than the cure?
Well, the pills can they certainly can be worse than the cure if they're used inappropriately, but if they're used appropriately in the right situation, in the right person with the right monitoring, we hope that all the clinical evidence we have from trials, etc., will actually back us up and it will improve the patient's life. Denmark again, sorry Danish, but it shows it can work if it's done properly. And gee, they have good monitoring. It really puts us to shame.
So good GP, good monitoring. That's what you're aiming for. Tim, is it?
One small thing that you've mentioned, I don't want to go on about it, but
the
issue here also is not just so much, we talked about it, the treatments for schizophrenia. The thing that drives me bonkers is everyone's on about 5 medicines. Now, and when people come to our clinic to learn what to do, they say, well, I suppose you're going to stop the antipsychotic. And I say, no, I'm going to stop all this other junk they've been put on because it has no purpose. I have no idea why they've been put on it. Now, there's a thing called epilepsy. If you don't have bipolar disorder, which it is useful for, you have schizophrenia, there's no evidence it does you any good, but it makes you fatter than clozapine. 60% of people are on it, and I can't find out why. So that's an example of too many medicines without a reason. Don't point the finger at the anti-schizophrenia drugs. It's often the other junk that people throw in for whatever reason.
A comment from Phil, if you could pass the mic.
I just wanted to make a very quick comment about smoking, which is, I think that's exactly the reason why the Cancer Council would like to see more support for people with mental illness to quit smoking in the community. Then we'd have less of a problem with people going in and out of hospitals. And I would just say the second point is, there was a study in India which actually found that smoking rates amongst people with schizophrenia in India were lower than in the general population. And I think we have to look at, you know, how many smokers have been created by the mental health system. I've had people ring me up and complain people took up smoking in a psychiatry. They weren't smokers when they went in, and they were when they came out. And so they emerge with a life-threatening disease. Because to me, smoking is a chronic disease, and I think that's the general medical thinking, it's a chronic medical illness.